Hello and welcome to the differences between diabetes insipidus, abbreviated as DI, and syndrome of inappropriate antidiuretic hormone secretion, abbreviated as CIADH. Okay, so we're going to give differences in terms of definition, causes, urine output, the thirst. They have a difference in thirst. We also have a difference in terms of serum sodium levels. Which one has high, which one has low. We also have urine specific gravity. Then you have plasma osmolarity, you have fluid balance in terms of the differences in terms of treatment, clinical presentation, and lastly the hormone that is involved in the difference. So welcome to the presentation, guys. So we know that diabetes insipidus is normally leads to reduced production or response to ADH secretion. So like for reduced production, we have the central diabetes insipidus, and reduced response to ADH, we have the nephrogenic diabetes insipidus. And all these one, they normally lead to excessive urine production and water loss. Since we know it is ADH responsibility to ensure that water is conserved. But when there is non-ADH, it means you are going to have excessive urine production and water loss. So CADH, syndrome of inappropriate antidiuretic hormone, leads to excessive release of ADH, okay, and this one causes the kidneys to retain water excessively, yeah, including the solutes, okay, including the solutes. Remember, when you're losing the urine, you're also losing the other solutes in the body, okay. In terms of urine output, you find that diabetes insipidus will normally produce large volumes of dilute urine, polyuria. More urine is being excreted, whereas syndrome of inappropriate ADH will lead to decreased urine output due to water retention. In terms of specific gravity, yeah, we have diabetes insipidus. In diabetes insipidus, we have low urine specific gravity due to dilute urine, okay, urine specific gravity. So more solutes are being lost, okay. Remember, somebody will ask you, what does urine specific gravity mean? Urine specific gravity is a measure of concentration of solutes. Yeah, they could be such as salts or other dissolved substances in urine. We are comparing it with the concentration of pure water, and this one is normally a valuable diagnostic tool in medicine. Okay, so you're just looking at the measure of the concentration of solutes in urine, and you are comparing it with pure water. So in this case, you find that in diabetes insipidus, we have low urine specific gravity due to dilute urine. This is compared to syndrome of ADH, whereby we have conservation of water, and this one and other solids. So in this case, we have high urine specific gravity due to the concentrated urine. Let's look at in terms of thirst and fluid intake. What is the difference between the two conditions? In diabetes insipidus, we have intense thirst. Yeah, intense thirst, polydipsia, okay, polydipsia, due to fluid loss. So somebody has lost fluid, is going to be thirsty. What about CADH? Have you lost water? No. Okay, so we have decreased thirst due to water retention. So you still have more water. What about the difference in terms of sodium levels? You're saying that we have serum sodium levels are usually elevated due to water loss. So you have lost water, you have the sodium. So we are going to have hypernatremia. Okay, but in CDH, we have sodium levels are usually decreased. So somebody is going to have hyponatremia because of water retention. Okay, because of the water retention. What about the fluid status, guys? So patients are often dehydrated and have decreased blood volume for diabetes insipidus. Whereas in syndrome of inappropriate ADH, patients have fluid overload and they have expanded blood volume. What is the cause of thirst? You find that thirst is triggered by dehydration and increased serum osmolarity in diabetes insipidus, whereas thirst regulation is impaired in CIDH, so due to inappropriate ADH release, leading to dilutional hyponatremia. Let's look at the difference in terms of treatment approach. Remember, the cause for DI, diabetes insipidus, is we don't have ADH, or ADH is there but the kidney is not responding to it. So what is the treatment? We replace it with ADH, okay? If it is central diabetes insipidus, okay? But if it is the nephrogenic, where the kidney is not responding to the ADH, you will need to treat the underlying cause. What about the syndrome of inappropriate antidiuretic hormone? We treat the cause, we restrict the fluid, and we possibly administer medication to inhibit ADH release. In terms of fluid and electrolyte imbalance, diabetes insipidus, there is risk of hypernatremia and dehydration. Okay, so you can give more fluids, right? Yeah, yes, you can give more fluids, yes, to dilute and to correct the dehydration. What about in syndrome of inappropriate ADH? There is risk of hyponatremia and fluid overload, guys. We need to restrict fluids in CADH. So the common causes, we have said that diabetes insipidus could be caused by brain injury, tumors, surgical trauma, or genetic conditions. Whereas syndrome of inappropriate ADH could be as a result of lung diseases such as brain injury, tumors, medication, or certain conditions affecting the hypothalamus or the pituitary gland. Guys, we have to remember that the hormone involved in diabetes insipidus, we have ADH, which is also known as vasopressin. It is missing in action, guys. Whereas in CADH, we have this same hormone that is in excessive amounts, guys. It's in excessive amounts. So we have to try and reduce, okay, the production in CADH. So those are the 11 differences between diabetes insipidus and syndrome of inappropriate ADH secretion. Thank you so much and have a fantastic day.